Hi, thanks so much for joining us today. We are fortunate enough today to have Chelsea Hertel, who's a registered dietitian who specializes in oncology nutrition at Nuvance Health. We often hear the expression, you are what you eat. And in a lot of aspects, that is very true. Nutrition is tied to cancer risk, and different cancers carry different risks along with what we're eating. So, at the end of the day, we are what we eat. One of the things that actually has nothing to do with cancer nutrition, but Chelsea, I always thought a registered dietitian and nutritionist were the same thing, but I'm not actually sure if that's true.
Yes, so a lot of times the name gets used interchangeably. I do get that in my day to day, especially with colleagues, because I do work for the nutrition department. So it would seem logical that I would be a nutritionist. But there are differences between the two. So as a dietitian, I had to attend school for a certain amount of years. I had to do a supervised practice, which we refer to as a dietetic internship. I sat for a standardized exam, and then we're required to do continuing education on a 5-year cycle period.
Wow.
Also, dietitians may have specialties. So if you, for example, I'm a CSO, which is a certified specialist in oncology. To have a specialty, you do have to do additional years of training and sit for an additional exam. So for nutritionists, some do have credentials in the state of New York. You can be a CDN, and as a CDN, you do sit for the same registered dietitian exam, but you're just missing that supervised practice component. But other nutritionists are essentially self-proclaimed, so they don't have any schooling. They may have taken 1 or 2 courses or read a book. And that's where we tend to get into some issues because they may not be giving the most evidence-based recommendations, and patients end up confused at the end of the day.
So my take-home message from that is if you are seeing a specialist to discuss your dietary intake due to health reasons or other reasons, you should be seeing a registered dietitian.
Yeah, or just confirming that the person does have the appropriate credentials. So a CDN in the state of New York still does have schooling requirements. So I would just make sure that they have a minimum of the CDN, if not an RD after their name.
Okay. See, this proves that you really do learn something every single day. I was not aware of the difference. So thank you for what you do. As a breast surgical oncologist, I know that I refer a lot of patients to dietitians because of the link between cancer risk and diet, especially when we're talking about obesity and maintaining ideal body weight. So really, what is the tie-in between obesity and cancer risk?
So there are many different factors that play a role. Essentially, obesity can increase risks of many chronic conditions, including cancer. For a person who is overweight or obese in regards to cancer care, obese patients tend to have a diagnosis that is referred to as metabolic syndrome, which just is a fancy term that stating that the patient has many conditions that are related to eating unhealthy and leading an unhealthy lifestyle, like cardiovascular disease, high blood pressure, and one of the things that falls into that is insulin resistance. So for someone who has insulin resistance, the high insulin levels and high what we call insulin-like growth factor can lead to cancer spread. The other thing in terms of obesity is that there is a hormonal component. So for our breast patients who have estrogen positive disease, estrogen is stored in the fat cells. So essentially, the more fat the person has, the more estrogen they may have to essentially feed that hormone sensitive cancer. There's a similar component in GYN cancers as well. And then also, cancer is an inflammatory process. And for someone who is obese, they just have an underlying chronic inflammation. So the two kind of go hand in hand. And there
So
are
are the fat cells related to inflammation at all? Is there a correlation there?
There is, yes. So the more fat cells person has, the more underlying inflammation they have. And that inflammation essentially influences cancer growth and development, not only for breast cancer patients, but for many cancers. There are several cancers that are related to obesity. So not only breast cancer, but colorectal cancer, esophageal cancer, pancreatic cancer, prostate cancer, a whole slew of cancers.
Wow. So for someone who, and is there a medical definition of obesity? You know, I'm a few pounds overweight. Does that mean I'm obese? How do we figure that out?
So we figure that out with the body mass index, which is a calculation. We use the patient's height and weight to determine. So if a person is overweight, they have a body mass index or a BMI greater than 25. For someone who is obese, and there's 3 classifications, 1, 2, and 3, it's going to be greater than 30, and it kind of goes up the ladder. As it increases, the class increases.
And what is the ideal body weight or BMI?
So the ideal would be from 18.5 to 24.9. The ideal body weight range would be dependent on the person's height.
Okay, and does age affect that at all?
It does. So for people who are over the age of 65, we do want them to be a little bit higher in the BMI range.
So as I get older, I can gain more weight?
Yeah.
All of a sudden, I'm loving getting older. Is that's true, and why?
So with age, we're worried about the loss of lean body mass and bone density. So having a few extra pounds on the body is helpful in that sense. When a person is losing weight unintentionally with age, a lot of times it comes from muscle mass. And with muscle loss, they may feel weak and tired and have a hard time getting through their daily living activities. So we do allow for a little bit higher in the weight and the BMI scale.
So let's say I am in incredible shape. That's it. As I say, let's just say that. But let's say I'm in incredible shape and I'm very toned and very fit and have very little body fat.
Mm-hmm.
So will my BMI be higher then because I have more muscle? Does muscle really weigh more?
That's a great question. Yeah. So with people, for example, if someone was a bodybuilder, their body mass index might be higher because of the amount of muscle mass that they have on their body. So we essentially have to use our clinical judgment when we are looking at the body mass index and identify is it an accurate reflection of their body makeup and composition, or is it an inaccurate value because of the amount of lean body mass the person has?
Very, very interesting. I'm learning a lot on this.
Oh, good, I'm glad.
Is there a way that individuals can find out their BMI without going to the doctor?
There is. So what you would do is you would divide, and it's probably easier for them to just Google it because it is a long calculation, but what you essentially do is divide your weight by your height in inches squared, and then you multiply that by 703. So
sounds
probably,
like I should just go to an app and look it up.
Easier to go to Google and put in your height and your weight, and it will factor it out for you. There are several charts that they have where you scroll over to your height and you look down to your weight, and it will tell you as well. So you can also Google image it, but yes, there is a calculation.
Okay, so again, between 18.5 and 24.9 is what we want. That's ideal.
That's ideal.
Okay, great. So what you've already told us is that our weight can affect our cancer risk, which I'm not sure that that's a well-known fact out there. How do we get that word out there?
Well, there's many organizations out there that do put out nutrition recommendations and diet recommendations to help decrease cancer recurrence risks and help with cancer prevention. So the main organizations we get nutrition recommendations for the cancer population is the Academy of Nutrition and Dietetics, the American Cancer Society, the American Cancer Institute for Research, and the World Health Organization. So there's a few organizations out there. They do extensive research to determine that there is a component between diet and lifestyle and decreased risks of cancer development and recurrence. So we do have a lot of information out there, and then each cancer site has specific recommendations. So there might be different diets for one cancer versus another.
So really the two cancers, or I guess that there's several, but the two more common cancers that we know about linked to obesity or our weight are breast and colon cancer, correct?
Yes. So I think we do hear a lot more about the breast and the colon cancer, and I think that's just because of the prevalence. There's higher incidences of those two types of cancers. But yes, you're right. We do hear a lot about the obesity rates and the diet and lifestyle components for both breast and colorectal cancers.
And you know, one of the things that I've heard about with colon cancer and diet is talking about a high fiber diet. And
Correct.
It's a very common phrase that's put out there. Oh, we should eat a high fiber diet. What really is that, and why is it important?
So fiber is the portion of the grain that does not get fully digested. And because of that, it helps to move stool and waste product out of the body. So for colon cancer, the longer the stool is in the GI tract, the longer that GI tract is exposed to waste products and the more chances of cancer development. In the breast cancer population, because it's not fully digested, that fiber helps pull estrogen along with it out of the body. So it helps us to decrease the amount of estrogen that's reabsorbed and potentially driving those hormone sensitive cancers. Fiber is going to be found in foods like your fruits and vegetables. It's going to be greater in the raw fruits and vegetables as opposed to cooked or canned fruits and vegetables. It's going to be in whole grains like wheat breads, brown rices, quinoa, bulgurs, beans, nuts. So those foods are the ones that are generally recommended on those high fiber diets. The other thing with high fiber is those fruits and vegetables that are high in fiber generally also possess something called phytochemicals, which are basically just the component that gives them the color. The more phytochemicals it has, generally the more health promoting properties.
So let's say that I really don't like what you just spoke about with eating a high fiber diet. Is there another way that I can take in fiber? Is there a pill? Is there a mix that I can put in my food or drink to get that fiber?
There is, but generally we do try to meet nutritional needs with food sources first before we go to some of those synthetic forms. Generally, if it's absorbed a little differently from the food source to the synthetic form, and you're typically getting more benefits from the whole food source.
So the other no shortcuts.
I would try to do the fiber from the whole foods, but maybe if you don't like fruits and vegetables, maybe you do more whole grains. So you kind of making gradual goals for lifestyle changes. We obviously don't anticipate patients to change everything overnight. So realistic and small goals.
Okay, I think that's a good message for a lot of things and really for life. Let's talk about soy for a bit. You know, in the world of breast cancer, whether someone is at average risk or someone has had breast cancer, we hear a lot about soy. Should they
Mm-hmm.
eat soy? Should they not eat soy? And why? Why do we talk about soy so much?
Yes, so we get that question quite a bit with our breast cancer population, but also with our GYN and prostate cancer patients.
True.
And the reason for that is soy. The confusion behind it is if you look under a microscope, soy looks chemically similar to that of estrogen. It has what we call phytoestrogens, which just means it looks similar to estrogen. So because of that composition, we think that it looks the same, it must act the same, but it actually doesn't have a hormonal component. So research shows that we can safely eat soy in the hormone sensitive cancers, whether it be breast, GYN, prostate cancer, and also for breast patients who are undergoing endocrine therapy. What we do recommend with soy though is that patients eat soy whole foods, kind of what we were talking about with the fiber.
Mhm.
So a whole food would be something like soy milk or edamame versus a soy supplement, like a soy isoflavone capsule. And the reason for that is our research really revolves around soy whole foods, and we don't have as much research to confirm the safety of the supplements and the synthetic form of soy. And we do have also some information out there regarding the Asian population, as they tend to eat more soy than the American population, and there tends to be lower breast cancer rates in the Asian population.
And they have higher rates though of other cancers.
Right.
So it seems like there's always a trade-off.
Trade-off, yeah,
So is
absolutely.
there an amount of soy that's too much, or it doesn't really matter?
So we don't want everything in moderation. So because of the fact that we're saying it's safe to consume, we don't want you to be eating soy for breakfast, lunch, and dinner. But generally, they say 1 to 3 servings of soy a day is safe to consume. So if you're doing soy milk in your cereal and then edamame maybe in a salad later on, that's okay to do.
You know, it's interesting that unfortunately we don't know a ton about nutrition. It's just one of those things that we're not typically educated about. And honestly, I can say you go to your doctor and they, if you're overweight, say lose weight, but we don't really talk about nutrition very much. And one of the things that I heard several years ago, which was just, it was almost like a light bulb moment. And it was talking about how we put food on our plate. And typically we put carbohydrates, the rice and the pastas on first. And that takes up half of the plate or more because we're putting it on first. And that doesn't leave much room for everything else. And then we may put on protein, and that will, just by intuition, now we only see half the plate left, so we'll put on half of that. So that leaves about 25% of the plate for protein and then 25% for vegetables. And what this person was saying is if we just change how we put food on our plate and we put on vegetables first, that'll take up half the plate, because whatever we put on first is about half the plate. And then everything goes in half from there. So just by changing the way we put food on, we can make a big change in our diet, which really just shocked me because it's such a little thing, but can have such large results. What do you think of that?
So it sounds like they were referring to something similar to what we call the My Plate method. So years ago, we used to use the food guide pyramid, which became difficult for not only the general population, but sometimes even for the nutrition staff to determine what's a serving of carbohydrates, what's a serving of fruit, how many should I have by the end of the day?
My serving may be different than your serving. What's that mean size-wise?
Exactly. So the My Plate came into play, and what that is about a 9-inch plate. So it's closer to a lunch plate size versus a dinner plate size. And what that's intended to do is kind of trick your brain to feel like you're getting more because the plate is full. So it looks like there's more value there. You're going to be full longer. It's going to be more satisfying versus if it's on a large plate, it's kind of small portions scattered out and you get these negative associations. This isn't enough. What am I going to have seconds of? and you're
Right.
already preparing for that next helping.
And
So
so
with
many
this,
people grew up with that. You have to finish your plate. So it
exactly,
is that mindset of whatever's there, I can't waste it. I have to eat it all. So it makes
right.
sense that if we
Yep.
have a smaller plate, we eat less.
Right. And then with that plate, what we would recommend is a quarter of the plate of a lean protein. So something like chicken or turkey or fish, a quarter of the plate of a whole grain. So maybe brown rice or whole grain pastas or beans, and then half a plate, like you mentioned before, of vegetables. So kind of making sure you're getting enough of one food source and not enough of the other. You're equally distributing it throughout the plate.
And will that add to weight loss, or is it just healthy eating? Are they the same? There's a lot of confusion about this.
So because you're using a smaller plate, the idea is that you're getting less calorie contribution, which can ultimately lead to weight gain. If you're eating too many calories, you're gonna either maintain or gain weight. The other thing is those vegetables that are filling up half of the plate are typically low calorie. So, and they do have fiber, so they fill you up for a longer period of time. Fiber is satisfying. And then you have your lean protein. So with the lean protein, that's also a satisfying item. So sometimes people find themselves grazing between meals when they're not getting enough protein in. So it should not only help you eat healthier, but also help with weight maintenance and weight loss goals.
Yeah, I mean, thank you so much, Chelsea. I have to say, I have about 30 more questions that I could come up with because, again, even as a physician, I can say we don't get a whole lot of education in nutrition, and it's important for us in our lives, in our families' lives, but important for everyone out there. So I hope you'll come back and speak to us again and educate us more on
Yes, so
this
that's
topic.
what we're here for, to kind of weed out the fact versus fiction and help patients individualize and plan their meals, not only for cancer risk, but there's many diagnoses that are related to eating unhealthy and leading unhealthy lifestyles. So that's what we kind of meet with each patient and see what their specific needs are and cater their meal plan to that.
Well, great. Thank you so much, Chelsea. This has been incredibly educational and informative. Thank you.
No problem. Thanks for having me.
Thanks.